this is going to be a little review because we've already went through lab reproductive system and we've already done hormones that we'll talk about as well in lab. But some reproductive organs that you're going to find in the female reproductive tract. The biggest one is the ovaries. It is the female gonads. It makes two main things. It makes eggs or gametes and it makes hormones. So it makes two things. Now, the two main hormones that it makes are estrogen and progesterone. So the ovaries, are the female gonads. What are the male gonads? The testes also makes the gametes, sperm, and hormones, testosterone. And I'm like, so they do the general basic thing of making gametes and hormones, but yes, different gametes, egg versus sperm, and different hormones, estrogen and progesterone versus testosterone. Other internal genitalia, all things found in the pelvic cavity other than the ovaries, the uterine tubes, fallopian tubes, oviducts, whatever you want to call them, the uterus, the vagina, and then there's also the external genitalia that all makes up the female reproductive system. And we'll talk a little bit more about the different parts as we kind of start with the ovaries, and then work our way to the outside of the body. So the ovaries, just some basic terms when we're talking about things inside the ovaries. One, if we're talking about a vesicular or antral follicle, it's got like 4 words. A vesicular follicle, an antral follicle, also called a Graafian follicle, and that we just called it a mature follicle. It's like 4 things that all mean the exact same thing. It just means it has the mature, it's a mature follicle, it's ready to get ovulated. Now, the reason why we can call it an antral follicle is because part of the fluid that's found inside of there is called the antrum. So you have this big chunk of fluid in there. Ovulation, which we'll talk about, is the ejection of an oocyte, that secondary oocyte, from that mature follicle. And then after ovulation, that follicle that was getting that secondary oocyte ready to eject during ovulation, the rest of it will become what's known as the corpus luteum. We'll talk about that when we get there too. Now, after we leave the ovary, the uterine tube or fallopian tube or oviduct or whatever you want to call it, now its main job is to receive that ovulated oocyte, that ovulated egg. It is also the usual site of fertilization. People think that the egg is fertilized in the uterus. It's not. Those sperm have to go all the way through the uterus and all the way up into the fallopian tubes and find the egg in the fallopian tube and then fertilize it there. And that fertilized egg takes several days to travel down and then will implant in the uterus. But it's fertilized all the way up in that fallopian tube. Now, a couple different regions on the fallopian tube or uterine tube, if I had another picture coming up, is the isthmus. I'm horrible at drawing things. Here's your ovary. There's your fallopian tube. Right? Sure? And the isthmus is the end part, right where it comes together with the actual uterus itself. The ampulla, I should have drawn it a little bit better. It's kind of like the curve. I'll draw the egg up here. There's your fimbriae. And it's the little curve. It's called the ampulla. It kind of goes up and then curves back down. So it's the little arch. And it's usually in the ampulla region, this little arch area, where you actually have the sperm meeting the egg. So shortly after it gets into the fallopian tube, it's kind of starting to go over the arch. That's usually where the sperm find it and fertilize it. Now, we looked at in lab. The expanded little funnel area, there's your infundibulum. And then we have our ciliated fimbriae. At the end of that, it again is little finger-like projections that sit there and try to create currents. Because your fallopian tube and the fimbriae are not actually connected to the ovary. There's space in there. They are not connected. So if an egg is released from the ovary, it's not a guarantee that it's going to make it into the fallopian tube. It can make it out into the actual peritoneal cavity. It's not going to make it. So those little fingers try to create a current to try to make it so the egg tries to float into the fallopian tube. I'm not going to watch the little video. Now, some things that can happen, though, is that egg that was released is fertilized somewhere other than the fallopian tube. We call it, and it usually will implant somewhere else, or it can implant somewhere else as well. It's called an ectopic pregnancy. And so again, usually that egg is fertilized, and it will eventually make its way down, and it will implant itself into the uterine wall. There we go, there's my fertilized egg. If, however, it lands somewhere else and tries to attach itself and tries to go somewhere else, it's called ectopic. Now, occasionally, since they're not connected, that egg could get released and it's just hanging out in the peritoneal cavity. It's possible that sperm travel all the way up and out, and they fertilize the egg outside of the female reproductive tract, and it will try to attach to something as well and try to grow. It will not grow. And I'm like, there's no other part in the female body that can sustain pregnancy except the uterus. And so it generally naturally aborts by itself. Usually there's lots of substantial bleeding. Normally I'm like, most of the time it's rare that I hear it hanging, happening in the peritoneal cavity. Happens. But occasionally that fertilized egg but I'm like, occasionally it will attach itself into the fallopian tube and tries to grow there as well. Again, fallopian tubes cannot sustain a 9-month size fetus. It cannot stretch. It doesn't have the nourishment. The child will not live. Now, normally it aborts by itself. However, if it's not aborting soon enough, and this starts to grow big enough, because it can grow for a little while, it can burst the fallopian tube and cause a lot of other problems that sometimes they'll go in and try to remove that before that happens. Also, because this is not connected here, you can also have an infection, one that can spread from the reproductive tract. So if you've got bacteria, here's my bacteria, they're blue, there you go. They left the reproductive tract and now you have bacteria in the peritoneal cavity. And so you can have infections that start in the reproductive tract, and because they're not attached, can go out into the peritoneal cavity. By having any type of infection outside of that actual reproductive tract, and I'm like, we can't fight the infections as well, it may lead to scar tissue, it may lead to infertility. I'm like, it's pelvic inflammatory disease. It's usually going to cause a lot of pain, sometimes a lot of bleeding that goes along with it. Now, the uterus, it's hollow, there's nothing in there until you're pregnant. And I'm like, thick-walled muscular organ, because there's that whole myometrial thick-walled layer in there. Function is to receive, retain, and nourish that fertilized ovum, that fertilized egg for 9 months. It's made to receive a fertilized egg, nourish it, and maintain that pregnancy for 9 months. The major portion of it, the main part, is the body. The fundus is the rounded top. The isthmus, we didn't talk about it in lab. It's just the narrow region. It's before you get to the cervix. Shouldn't have. I'm like, I don't want to draw all of it. I'm not great anyways. Something like that. I'm like, it's just the narrowed region at the very bottom. It's called the isthmus. Sorry if I offended anyone with my picture if you drive a Dodge. And I'm like, I just thought it was funny. Sorry if you drive. The uterus at the very bottom, though, we do have the cervix that does hang down into the vagina. And around the cervix, we have cervical glands that secrete mucus that block sperm from getting into the uterus itself. So there's generally some type of mucus there. Now, it will block sperm from getting up into the uterus except around the days that ovulation happen. Otherwise, and I'm like, really what this mucus is trying to block is bacteria from getting up in there. And I'm like, you're right, it will block sperm from getting up in there, but it also is really trying to block any type of bacteria from getting up into the uterus and up into your upper reproductive tract and possibly causing some type of infection. Now, the things that can happen with the cervix. Cervical cancer. That 450,000 women worldwide every year get cervical cancer, and it's a deadly one. About half of them die because of it. It's most common diagnosed between the ages of 30 and 50. If you've made it to 50 and you haven't had cervical cancer, your chances actually go down. Normally, cancers, as you get older and older and older, all chances go up. Cervical cancer is kind of like a bell-shaped curve. Your highest chances of getting diagnosed is between 30 and 50. If you've made it to 50 and you haven't had it, your chances actually go back down. Risks for developing cervical cancer: frequent cervical inflammations, sexually transmitted infections, multiple pregnancies. And what they'll do, a pap smear, if you had no idea what pap stood for, it's because they don't want to say that big long word. It's the Papanicolaou. And you're like, yes, I'm going in for a Papanicolaou smear, is what they're doing is they're actually scraping part of that edge of the cervix, and they're looking for any abnormal cells. And like that could indicate that there is some type of cancerous cells, some type of abnormal growth that's growing on there. Now, occasionally, your pap smear results may be inconclusive, and you're like, I don't know, there looks like some abnormal cells. Doesn't mean they're out cancerous or not, but they'll constantly check you more regularly to see if it increases in frequency. They're also going to test you for a virus, the human papillomavirus. There is a virus, the human papillomavirus, that is really the main reason, and I'm like, or the main cause of cervical cancers. Now, what's nice, within the last 10, 15 years, we have developed a vaccine against that particular virus. Have you heard of it? Gardasil? I'm like, I'm too old to get it now. But I'm like, to get the vaccine, but it's a 3-dose vaccine. It protects you against this particular virus. That doesn't mean you're 100% can't get cervical cancer. However, since the cervical cancers are normally or usually caused by this particular virus, your chances of getting cervical cancer go way down. Doesn't mean you're exempt, because there's other things that can cause it too, but your chances of getting it go way down. Now, I was going to say it's recommended to start the 3-dose regimen between 11 and 12-year-old girls. Now they're also recommending it for boys. Just because boys don't have a cervix doesn't mean that virus, the human papillomavirus, can't cause other cancers. It can also cause anal cancers. It can cause genital warts. And so I'm like, it protects males as well. So it protects you against cancers, male and females. It protects you against genital warts, males and females. It's a good vaccine to get. I was going to say, some of this you know already because we went over this in lecture, but yes, the uterus has 3 layers. The perimetrium on the outside, myometrium, muscle layer, endometrium, that's the inside the mucosa lining, which we're going to talk more about. Because it's that endometrium layer, that inside layer that gets shed every month. Now, that endometrial layer actually has like 2 sublayers. There's the stratum functionalis. This is the part of the endometria that gets shed every month during menstruation. And I'm like, it changes. We'll get into the ovarian hormones and the hormones that makes it grow and then get shed. And then you can't shed all of it because you still need something left over to build the whole thing up again. So you have the stratum basalis, or the basal layer. It's the base layer. You can't shed that. You can get rid of the whole functional layer, functionalis, but you're left with the base layer to then rebuild the functionalis layer. The vagina, I was going to say thin-walled tube, about 8 to 10 centimeters in length, 3 to 4 inches. It has 2 functions. It's a birth canal. Baby has to fit through there. It's also the organ of copulation to receive sperm. The urethra runs right along parallel, right along with the vagina. The external genitalia, again, some of this we went over in lab, so I'm kind of flying through some of the structures. The mons pubis, the fatty tissue area that sits right in front of the pubic bone. The labia majora, the hair-covered outer fatty skin folds. Inside of it is the labia minora. One thing we didn't talk about in lab is that sitting inside the labia minora, we have greater vestibular glands. They're on either side of the vagina. They're glands, so they're going to make something. They're going to make a secretion that's similar to what the bulbourethral gland does. And I'm like, it's for lubrication. It's also to help, it's slightly alkaline to neutralize any urine, any acidic urine that might be there. And it helps, I was going to say, well, I already said that, for the lubrication. And then the clitoris is right in front. So I'm going to say the vestibule. The word vestibule just means the entrance area. So it's near the front of the external genitalia, and it's the counterpart of the penis. We kind of saw in lab the material found in the penis, the tissue, the corpora cavernosum, that actually makes the penis become erect. That same exact corpora cavernosum is also found in the clitoris as well. Mammary glands, same job. They function in milk production. Now, your mammary glands are supported by suspensory ligaments that attach the breast tissue to underlying muscle for support. They contain glandular alveoli, so those alveolar glands that make the milk. Once milk is made, it will travel through lactiferous ducts, into lactiferous sinuses. They're all kind of coming together, and then they all go out through the nipple area. Your breast size is just determined by fat deposits. The only time it changes is if you're actually lactating after giving birth. Then the size can change because those alveolar glands are actively producing milk and they enlarge. Otherwise, breast size is all determined by how much fat deposit you have there. I was going to say, there's all of your lactiferous ducts, and the enlargement is your sinuses, but they all of them go out through the nipple itself. Things that can happen with breasts is breast cancer. 13% of all U.S. women will develop breast cancer. It ends up being about 1 in 8. And so just looking around, we probably have 16-ish women in here. So statistically, 2 of us will develop breast cancer. And so I'm like, that's a lot. And I'm like, so 2 out of us in here will statistically develop breast cancer. Now, it's usually a cancer of the ducts. So some epithelial cells in the ducts, your lactiferous ducts. It's not in the actual gland itself, but it's some of the epithelial cells that are found in those lactiferous ducts. The problem with breast cancer, which makes it deadly, is that those cancerous cells like to metastasize, which means what? I was going to say it likes to travel. They like to break apart and travel throughout the body. So hopefully it's caught before that happens and taken care of. Now, risk factors for breast cancer. Early onset of menstruation. So the first, at what age were you when you first get your first period? Late menopause, depending on if you're there or not. Having no pregnancies, or your first pregnancy is late in life. So you waited a long time to have kids. No or short periods of breastfeeding. Or if you have a family history of breast cancer. These are all risk factors that increase your chance of breast cancer. And if you're like, oh my goodness, that's me. And I'm like, yeah, I fall into a bunch of those. Luckily, 70% of women that have breast cancer don't have any of those known risk factors. So it's like, yeah, they increase your chance. It does not mean that you're destined to actually have breast cancer. Now, your best bet is to get diagnosed. And the earlier the better, as they're going to do a mammogram. They're going to x-ray the breast tissue. They're going to look for any abnormal lumps. And again, the lump is because you've got cells that are actively dividing. Now, you can do your own breast exams and try to feel for any of the lumps. That's usually your best chance of catching it early. Otherwise, you can get mammograms. The American Cancer Society recommends every year for starting at the age of 40 and up. The U.S. Prevention Services Task Force recommends mammograms every year starting at 50. Which one do you think your insurance wants? I was going to say they want to go with this one. They don't want to start paying for mammograms until you hit 50. Now, and if you're like, oh my goodness, but I've got a family history, I've got all these risk factors, your doctor can petition, and I'm like, to get you mammograms and to make your insurance pay for it earlier. And so if you're like, but I've got every risk factor under the sun, you can get screened earlier and make your insurance pay for it. Otherwise, your insurance doesn't want to pay for it until you hit 50. Another thing that can cause breast cancer too, I know I put down, I don't know if I care about the abbreviation, but 10% of breast cancers are also caused by an abnormal gene. And they can actually screen for it. And so they can look like, hey, you have this abnormal gene. That means at some point in your life, you've got about a 95% chance of developing breast cancer. Now, and I'm like, that's something that runs in the family that you inherit, and they can test for that gene. It was a couple years ago, if you remember this, maybe I'm dating, maybe it's more than a couple years ago, Angelina Jolie. I was going to say, she had a mastectomy, because she knew, her mom had developed breast cancer. She had the gene, that 95% chance she was going to develop breast cancer. So instead of waiting for that to happen and the possibility of it metastasizing and spreading and killing her, she just right away had a mastectomy and removed the breast tissue. So then she doesn't have to worry about it. And so you can get tested for that as well. And I'm like, if you think, your parents run through it, and I'm thinking a lot of times they can detect and say, well, this is why they had the gene. You can get tested for it to see if you have the gene. Treatment kind of depends on, what kind of lesion or growth there is, if it's spreading, if it's not spreading, where it is in there. lot of times radiation, chemotherapy, surgery, sometimes more of the above. You have surgery followed by radiation and chemotherapy to make sure they destroy any remaining cells, cancerous cells that may have spread. If they do a radical mastectomy, this means they were trying to remove everything. They are going to remove all of your breast tissue, any of the muscles underneath, because they're afraid it spread to the muscles, any of the fascia that everything attaches to, and any associated lymph nodes, because if you get cancerous cells in your lymphatic cells, and or in your lymph nodes and in your lymph, they can travel anywhere throughout the body. This is usually if it's progressed pretty far, they're going to just remove it all. Lumpectomy, if you catch it early, they're just going to remove the lump. They might do a little bit of radiation, just in case anything spread. A simple mastectomy means they're going to remove the actual breast itself, and then sometimes your axillary or your armpit lymph nodes, because that seems to be the first place that it likes to spread to. All right, away from breast cancer, on to oogenesis, which the word means, I'm like, the making of eggs. Now, at birth, so the majority of you are females in here. You guys are all like my corner. At birth, when you were born, you had all the eggs you will ever have. Males, they start making sperm at about puberty, and then they make it for the rest of their life. You were born with whatever you will have. When you're born, you have about 1 million. I was like, somewhere between 500,000 and 1 million eggs at birth. Doesn't mean they're all going to be ovulated. That doesn't mean they're all going to mature, but you were born with a whole bunch of eggs. It's once you hit puberty, a few of those eggs will get activated to start to grow and then eventually be ovulated. Only one is selected each month to mature, so once a month for approximately 30, 40-ish years. I'm like, on average, you release about 500 eggs in your lifetime. I'm like, so you've got, 500,000 to 1 million eggs, and only 500 actually mature and are ovulated. Now, interesting part, and I'm like, about the fact that a female, my interesting factoid, a female is born with every egg that she will ever have. My interesting thing, so I have 2 daughters. So while I was pregnant with one of my daughters, inside of her were all the eggs that will eventually become my grandchildren. So it's like you're pregnant with your own grandchildren. Because I'm like, as she's growing, all the eggs that are in there, one of them, hopefully, will be my granddaughter or grandson. And so I'm like, it's kind of the interesting fact is that, yes, the eggs are inside of there. And I'm like developing, and one of them will be my grandchild. Not for like another 20-some years, hopefully. Lots of time. Now, there's 2 different cycles to go through. There's an ovarian cycle. What's happening in the ovary of getting these eggs to mature and be released. And there's also a uterine cycle. What's happening in your uterus as well. Both cycles, because I'm going to talk about one, then I'm going to talk about the other, are about 28 days long. And I'm like, they can vary. We're just going to pretend today they don't, and they're exactly 28 days. Now, so your ovarian cycle, it's your 28-day cycle, which you're maturing the egg, releasing the egg, and getting it ready. Your ovaries doing various things to get ready and make sure your whole body is ready for that egg to be fertilized. Now, there are 2 different phases in your ovarian cycle. There's the follicular phase and the luteal phase. And ovulation is right smack dab in the middle. So you are preparing that follicle to finish growing, release the egg, and then everything that comes after is that follicle becomes the corpus luteum. Now, only about 10 to 15% of women actually have a straight 28-day cycle, but today we're going to pretend everyone does, and everyone has a 28-day cycle. Now, the interesting part, yes, only 10 to 15% have a 28-day cycle. Between the 2 phases, the luteal phase is always 14 days. Always. Never changes. It is 14 days. But if you're not on a 28-day cycle, you're on a 30-day cycle or a 25-day cycle. That means the follicular phase has changed a little bit. It's not on a 14-day cycle. But the luteal phase is always 14 days. Now, in the follicular phase, things are happening with the follicle. You have a primordial follicle. This is like before it's even a primary follicle. I've got a picture. Your primordial follicle. This is when you're born with, your 500,000 to 1 million eggs. They're really these tiny little primordial follicles that like to hang out right along the edge of the ovary, and they're just hanging out waiting for something to tell them to do something. So those primordial follicles will become a primary follicle, and eventually become a secondary follicle, which we didn't look in lab, don't care. It will eventually develop into your mature follicle. And so it's growing and growing during your follicular phase. So your primordia becomes primary, primary becomes a secondary, and it'll also eventually become a mature or Graafian or antral follicle. And then on dayish 14, you have your secondary oocyte in here. It will be released. I don't like this picture because it's like, looks like the sun. And I'm like, but this egg will be released outside of the ovary. And so here's your mature follicle, your secondary oocyte, that will be released on day 14. Now, and I'm like, some women actually can feel a little bit of pain right around their ovaries at day 14. That actually they know when they're ovulating. It's called Mittelschmerz. It's German, or something like that. And I'm like, you can actually feel pain. And I have students that are like, oh, I totally feel it. On day 14, they know. They can actually feel pain right around the ovaries, and they can actually know because you only release one egg out of either ovary, and they can be like, yep, came out of this side. I can feel the pain at day 14. It just feels like a little bit of cramping. For some students, I say, I'm like, oh, it lasts a few minutes. Some say it lasts a couple hours, and they know exactly which side is ovulating. I'm like, some can feel it. Some, and I'm like, because and there's kind of the, well, why can they feel pain? Well, it's bursting out, and so some can actually feel pain as that egg is being released and actually breaking out of the ovary. Most people don't feel a thing. 1 to 2% of ovulation release more than one secondary oocyte. Again, we generally only release just one oocyte each month, for how many years. However, if 2 get released and both of them get fertilized, twins, fraternal twins, 2 eggs are released, both were fertilized in the same month. If you're identical twins, and I'm like, it means 1 egg was released, that 1 egg was fertilized, and that fertilized egg splits. So again, they have all the same genetic information, hence the identical part. Now, interesting part, when that egg is ovulated, that egg is only viable for up to 24 hours. That's it. So it has to be fertilized within 24 hours after ovulation for a pregnancy to result. Small little window. Now, the luteal phase of the ovarian cycle. So we release the egg. That mature follicle that released the egg, that ruptured follicle, it collapses. The inner part of it, the antrum, that fluid that was in there, fills with blood. Let's call it the corpus hemorrhagicum, because it's filled with blood. However, the cells that make it will start to swell and enlarge, and we now call it a structure called the corpus luteum. Go back to my picture. Go back. Well, it's really slow. There we go. And I'm like, so if you notice, the cells are really, really tiny. And then it released the egg. These tiny little cells start to get really big and fat. And this is now the corpus luteum. It is this structure minus the egg and really fat cells. What that corpus luteum will do, it will secrete progesterone and some estrogen to help maintain pregnancy. Eventually, about 3 months later, if pregnancy results, the actual placenta will start producing and taking over and producing the progesterone. But until then, the corpus luteum increases your progesterone output to maintain and nourish that fertilized egg, if a fertilized egg actually happened that month. If no pregnancy occurred, that corpus luteum breaks down. It doesn't need to make any progesterone anymore, and it completely breaks down. It all goes away, and you're left with a scar called the corpus albicans, which sometimes I'm like, they want to know, if a doctor ever wants to know, I'm like, I was going to say, my story, I'm like, my sister-in-law, they had lots of difficulties getting pregnant, so they're always at the doctor. They could actually look to see, yes, you are ovulating, because they always want to see what's going wrong. Yes, you are ovulating. They can actually tell. They can look to see which ovary had ovulated and when. And I'm like looking at the size and kind of like how old the scar is. They're like, oh, you have a recent scar on your ovary on this side. And I'm like, from the corpus, called the corpus albicans. That means you had, the last month, you would release an egg, you would ovulate it, and now you've got a pretty fresh scar. So they can actually look to see all the scars. Anytime you've ovulated, once a month, you now have scar tissue on your ovary from that released follicle. Now, if pregnancy did occur, yes, it will continue to make your hormones, generally your progesterone, a little bit of estrogen, until that placenta takes over. Now, establishing the ovarian cycle of, yes, we're going to mature these follicles, we're going to release the egg, and we're going to have the corpus luteum. And I'm like, to get all of this going, we need more hormones. We've got estrogen, progesterone, but now we need to bring in more hormones. Now, and I'm like, during childhood, ovaries will continue to grow. And I'm like, so when you're born, your ovaries are really small. As you get older and older, your ovaries start to grow. That's partly because there's always a little bit of, there's small amounts of estrogen, not enough. Generally, it's kind of keeping your hypothalamus, inactive. As puberty starts to get nearer, around the age of 10, it doesn't mean puberty starts then, but around the age of 10, the gonadotropin-releasing hormone is released. And where is the gonadotropin-releasing hormone made? Where's it made? Hypothalamus. It's like lab questions. That's why I didn't write it up here. And so around the age of 10, the hypothalamus is going to start to release the gonadotropin-releasing hormone. Then, and I'm like, it will act on, and I'm like, or cause the increase of the follicle-stimulating and luteinizing hormone. And what makes these? Your anterior pituitary shortened. And I'm like, now it's going to become active and start making your follicle-stimulating hormone and your luteinizing hormone. And these are going to act on the ovaries. I don't think I wanted to write ovaries yet, though. Not yet. I was going to say I've got more stuff. And I'm like, but it will, it will act on the ovaries. And what are two things that the ovary does? Makes hormones. And? A little bit. But I'm like, that's the estrogen itself. And I'm like, the ovaries make hormones and? Well, that's what the hormones do. But what does the ovary do? The testes did two things too. What does the ovaries? Two things it does. Hormones and? It makes the eggs. And I'm like, so these two things are going to act on the ovaries to develop the eggs and start making hormones. And yes, the pattern of the hypothalamus controlling the anterior pituitary gland, acting on the ovaries to make eggs, develop them, and hormones. And I'm like, we'll continue from puberty all the way into adulthood until you get what's known as, I'm like, your menarche. That's your first menstruation. And it will continue all the way until you get to menopause, which we won't get there yet. So it's all these hormones eventually produces this 28-day cycle of maturing your follicles, follicle stimulating, and I'm like maintaining hopefully a pregnancy if we get there. And so you have your gonadotropin releasing hormone, we have our pituitary gonadotropins, follicle stimulating and luteinizing, and then eventually your ovaries are going to make estrogen and progesterone. Lots of hormones. So yes, males, when you say your females are hormonal, it's true. We are hormonal. We have lots of hormones that are going up and down every 28 days, because you're going to see that as well. Now, when you get your first period, or what will kick in, kind of the puberty, and I'm like, yes, it's all hormone. However, adipose tissue controls another hormone called leptin. And adipose tissue controlling the hormone leptin seems to increase or speed up the hypothalamus. And I'm like, so overweight females may generally, I was going to say, on average, have earlier first menstruations. And I'm like, because of adipose tissue. It's not the only reason. A lot of it is genetic as well, based on when mothers had their first period and grandmothers had it. So, I was going to say establishing it, some of that I said before, the gonadotropin level hormones increase, you're luteinizing, you're follicle stimulating, and it takes on average 4 years for this to be high enough before you actually start releasing eggs. So it takes a while to get these hormones at a high enough level, and I'm like, before you actually release an egg. So it takes a little bit to kind of get everything going. So during that pregnancy, or during that, no pregnancy can occur because you didn't release any egg. Eventually, you'll have what's known as menarche. That's your first menstruation. And then you're going to have approximately 28 days cycles. However, it can take a good 3 years before the cycle gets regulated. And so first menstruation, and I'm like, it could be 2 months before you have another one, you know, or it could be 15 days. And I'm like, it's about 3 years where it's just kind of all over the board. And I'm like, and then after about 3 years, it's pretty close to, oh, every 28 days or every 30 days, you kind of get on a regular schedule. Now, I was going to say, here's my picture that I was going to draw, but I don't like all the words, but yeah, it's got lots of information in it. I already started it off, but your gonadotropin releasing hormone, and I'm like, it tells your anterior pituitary gland to release your follicle stimulating hormone and your luteinizing hormone. Your follicle stimulating hormone, based on its name, will make your follicles grow. Oh. So your primary follicle becomes your secondary, or well, your primary follicle becomes a mature follicle. So the follicle stimulating makes your follicles grow. Luteinizing hormone, this is really unlike the big one for hormone, as you're going to start to have rising levels of estrogen. So you start to grow follicles, you start to have estrogen. However, there is some feedback if you have too much estrogen. And I'm like, one, I was going to say, increase of plasma estrogen. So it left the ovaries, it's gotten into your blood supply, will inhibit the release of follicle stimulating hormone. So enough of these will actually be a negative feedback on these. That's my negative. However, we still need to have enough estrogen in our ovaries to get everything going. We may not want a lot of estrogen in our blood supply, but we still want estrogen in our ovaries. And so some of these increase of estrogen levels can actually enhance more estrogen, but it will stay in the ovaries only. More colors. So estrogen can also be a positive for more estrogen. However, this estrogen is only, that extra estrogen is only going to stay in the ovaries. We need that estrogen in the ovaries to get those follicles to develop and get the cycle going. So estrogen is the negative feedback, and it's also a positive feedback, just depending on where that estrogen is going. Another hormone, other than estrogen, is a hormone called inhibin. Is a negative feedback on your follicle stimulating hormone. Inhibin is also found in the male reproductive system. It's also a negative feedback for the follicle stimulating hormone in the male reproductive system as well. Now, when the estrogen levels are high enough, I should just put a little, they're increasing here. When the estrogen levels are high enough, yes, you can have a positive feedback on the brain and the anterior pituitary gland. That's just so you get a lot of estrogen there. You can have stored luteinizing hormone. You can have some follicle stimulating hormone. And I'm like, a little thing, I'm like, your luteinizing hormone and a little bit with your follicle stimulating hormone, these two hormones are going to be the main reason why ovulation occurs. And so the luteinizing hormone is really your main one, a little bit with the follicle stimulating hormone. But at some point, you're going to get a huge rush of luteinizing hormone, and it will cause that mature follicle to release that secondary oocyte. So your luteinizing hormone, the effects at mid-cycle, day 14. By having a whole bunch of luteinizing hormone at day 14, you're going to have local vascular permeability, means more blood supply. It will also trigger an inflammatory response that's going to weaken your ovarian wall because that egg needs to leave it. So you're going to weaken the wall so it's easier for that egg to be released out of it. The blood flow is going to stop going through your protruding follicle wall. So the follicles are going to start to go to the edge of the ovary and it's going to start to protrude out. We're going to stop the blood from going to that follicle right along the wall, which will make that wall even thinner, bulge out even further, and it will actually rupture outside of the actual ovary wall. And so now you've got a hole in your ovary for that oocyte to leave. It's all because you're just decreasing that blood right along the outside of the ovary. That oocyte, the outside cells are just called the corona radiata. It's just the whole thing. It will leave and you've just ovulated. Now, after ovulation, your estrogen levels will start to go down, and that luteinizing hormone that triggered ovulation will now trigger that mature follicle to become the corpus luteum. And again, it's part of the name of the hormone. Luteinizing hormone caused that mature follicle that just ovulated to become the corpus luteum, where those cells start to swell and they start to make the progesterone. So it starts to make progesterone, some estrogen almost immediately. Again, trying to make sure our body's ready for a fertilized egg, or for an egg to be fertilized and to sustain it. That progesterone that it starts to make also helps maintain that stratum functionalis layer, that inner part of the endometrial layer. And I'm like, it tries to maintain it. It tries to make sure it has all the nutrients so that when a fertilized egg lands and implants there, and I'm like, it's ready for it. And it also helps maintain the pregnancy if it occurs. The word progesterone means for pregnancy. And I'm like, so it's there to try to make sure everything in the body is ready to try to maintain the pregnancy. Now, the negative feedback at some point, and I'm like, it all has to stop. When you get enough plasma progesterone, enough estrogen levels, it will go back and inhibit the luteinizing hormone, follicle stimulating hormone. So when you make enough hormones, it goes back and eventually it becomes a negative feedback to all of it. Now, if no fertilization occurred, we don't need the corpus luteum anymore because it was making progesterone to make sure we can sustain pregnancy, but it didn't happen. So the corpus luteum starts to go away because the luteinizing hormone goes down, and my corpus luteum goes away, and you have a sharp decrease in estrogen and progesterone. So they go away. Now, when you don't have any estrogen anymore, and you don't have any progesterone anymore, we're not going to have any inhibiting anymore. It's like, oh, we don't have any of this anymore. Let's stop any of the blockages. Let's stop any of the inhibiting, and let's start it all over again. Let's start making more estrogen. Let's start making more progesterone, and that's going to start at the top, stimulating the anterior pituitary gland. Now, a little interesting thing, an oocyte that gets released is actually activated about a year before ovulation, not 14 days. I don't think I have my picture. Those primordial follicles that just hang out on the outside, at about a year before they become ovulated, they get activated and they are starting to grow. And I'm like, for them to finish growing, it takes a little bit longer than 14 days. So they start to become primary follicles about a year ahead of time. It's only once you get enough of the estrogen progesterone, it activates some of those primary follicles to become mature follicles. So it takes about a year, and I'm like, to get everything going. Now, here's the rising, yes, the hormonal part. I'm too short to point to the top. There's your pituitary gland. It's making your follicle stimulating luteinizing hormone. The first 14 days-ish, they're about steady. Around day 14, you start to get that huge rise in luteinizing hormone and follicle-stimulating hormone. It's that major spike in luteinizing hormone which causes ovulation. Now, you can actually go to the dollar store and buy ovulation kits. What the ovulation kit is testing for is they are actually testing for how much luteinizing hormone do you have in you. If it's starting to go up, that means your body is getting really close to ovulating. And I'm like, so you can kind of determine, if you're almost at ovulating or not based on your luteinizing hormone. After ovulation occurs, there's your, here's your maturing. Day 14, you ovulated, they go back down. And I'm like, estrogen level also spikes around there. It's not until after ovulation that your progesterone level goes up. Again, progesterone is trying to prepare for pregnancy. And it's the corpus luteum with its big fat cells. It is making progesterone. So you don't really start getting a lot of progesterone until after ovulation when that corpus luteum starts to make the progesterone itself. Now, the endometrium lining will continue to grow and grow. Part of that is rising levels of progesterone, thickening of that endometrial lining, trying to make sure it has all the nourishments, nutrients, blood supply to withstand and nourish a fertilized egg that implants. Now, that was the ovarian cycle. What's happening in your ovary every 28 days? In your uterus, it also has a 28-day cycle. And of course, we call it something different. It's still a 28-day cycle, but the cycles are slightly different number-wise. So these are all things, what are happening inside the endometrium. The first 5 days is your menstrual phase. On average, it could be shorter than that, it could be longer than that. About on average, the first 5 days is the menstrual phase. Days 6 through 14-ish is what's called the proliferative or pre-ovulatory phase. You haven't ovulated yet. Your endometrial lining is just still continuing to grow. And again, the words in here, pro-life, is getting ready for life. Days 15 to 28, and I'm like, and that part is constant, it's called the secretory or the post-ovulatory phase. Again, it's continuing to grow in preparation for a fertilized egg. The secretory or post-ovulatory phase is a constant 14 days. These can fluctuate. Again, just like your ovarian cycle, that the luteal phase is an exact 14 days, that, it's after ovulation, it's 14 days. Goes in line with the endometrial lining and that secretory or post-ovulatory phase. They match up 14 days. Anything before ovulation switches around a little bit. Now, the first 5-ish days, the menstrual phase, this is when all your ovarian hormone levels are at the lowest. I don't want to go back too many slides. So your estrogen, progesterone, it's all low. And I'm like, everything dropped. Your gonadotropins are just starting to rise. Because when you have low levels of estrogen, progesterone, we're going to start the whole process over again and start making everything go back up. And so your gonadotropins are just starting to go up, your FSH and your LH. And this is when that stratum functionalis layer is shed. That also includes any blood supply that may be going to the particular area. And so the tissue and blood is leaving the body, which can take, usually it's 3 to 5 days that you're actually losing that actual blood and tissue. By around day 5, the ovarian follicles start producing more estrogen. And I'm like, you're starting to get the... Thanks.
You're welcome.
I'm not handing them out yet. You're starting to get the rising levels because you've got, your mature follicles. They're almost not quite mature yet, but you've got your secondary oocyte. We're starting to get all the levels going up in the ovaries. Now you're going to start building that whole layer up at the end of the day 5. Oops. The proliferative phase around days 6 and 14. Still, again, your estrogen levels are rising. You're getting more hormonal. Estrogen levels are going up. You're going to lay down more stratum functionalis layer. It's the layer that will shed. The glands start to enlarge, and I'm like, they're producing lots of nutrients for the endometrial layer. You start to get more arteries, more blood supply to that endometrial layer. Again, building everything back up. There's normally, in days 6 to 14, normally that cervical mucus, which I just erased, normally you have a thick cervical mucus, preventing sperm from getting up, but also preventing bacteria from going up. Days 6 to 14, it starts to thin, because by day 14, we don't want that thick mucus there anymore, because by day 14, we want sperm to be able to travel up and meet that ovulated egg on day 14. Ovulation just means you're now at the end of the proliferative phase. And after ovulation, you have the secretory phase. It's a constant 14 days. And the endometria is still finally preparing itself, or continuing preparing itself, spelled it wrong, for the embryo. You still have rising progesterone levels that came from the corpus luteum. That mean that functional layer, you're going to have more secretory, if I can say it today, a mucosa, just a thicker lining inside there. You're going to have more glands secreting more nutrients, and that cervical plug is going to go back. And I'm like, again, once you've ovulated and you get the sperm where the egg is going to be, we don't need more sperm up there. Egg only lasts one day. And we don't want bacteria getting up there and causing any problems for a fertilized egg. So it starts to build back up. Now, if fertilization does not occur, I was going to say more often than not it doesn't, the corpus luteum goes away near the end of the secretory phase, which means you don't have any more progesterone levels anymore. It goes away, don't need the progesterone. The endometrial cells begin to die. The glands start to go away. Again, their main job was to make secretions, to nourish, give it all the nutrients for a fertilized egg. We don't have a fertilized egg. Don't need those nourishments, don't need the nutrients, don't need the secretions. And what will happen is, as everything is starting to die, you will get one little rush of blood. That's kind of like one more final rush of blood, and it will make everything that's dying slough off. And so it's kind of like this little rush of blood makes everything that's dying and just kind of barely hanging on as it's dead, dying, slough off, and you start menstruation all over again. So here's, we're losing, and I'm like, there's your days 1 through 5. It kind of continues from over there. Building everything up, rising levels of estrogen. However, even though estrogen goes down in your secretory, your levels of progesterone go up, and you start to get lots of blood supply, lots of nutrients, and I'm like, everything just built up. Now, effects of estrogen. So we make lots of estrogen in our ovaries. Now, the estrogen promotes oogenesis, the making of eggs, and follicle growth. So your primordial follicles become primary follicles, become mature follicles. Hey, yay for the estrogens. Estrogen also creates rapid growth spurts in females. Now, anyone know about what age for girls you had your big growth spurt? I was going to say, some are right in there. And I'm like, it can go anywhere in there. And I'm like, it's on average around 10 or 11, give or take a couple years. It's not bad. I was going to say, it's kind of right around puberty or right before puberty is starting to kick in. 9. And that's exactly what happens. Estrogen kicks in faster than testosterone does. And so estrogen, around the age of 10-ish, females, and I'm like, female girls will have their growth spurt. Testosterone really kicks in and causes males to have their growth spurts a few days later, or a few years later. And so this is why if you go into middle school, what grade is 9-ish? 5th? 3rd? I should know this. And I'm like, but when you get in, I was going to say, around 5th grade, if you ever walk into a 5th grade classroom, generally all the girls at that age are taller than the boys. And I'm like, the testosterone usually doesn't kick in until around 13, 14. And then the boys start to catch back up again, and they have their growth spurt. But estrogen works faster and kicks in faster than the testosterone. So they have their growth spurt early, which also means they stop growing earlier as well. Other things that estrogen does, gives all the secondary sex characteristics of females. It causes the growth of breasts, increases deposit of fat on your hips, yay, and your breasts. And then it also causes the widening and the lightening of the pelvis, again, to prepare for childbirth. Some other things that estrogen does that I'm like, that has some metabolic effects, not reproductive, but metabolic. So they're not technically sex characteristics, but estrogen helps maintain a low total blood cholesterol, and it helps facilitate calcium uptake. So estrogen is good. Progesterone, its main job, it works with estrogen, and it helps maintain your uterine cycle, the building up of the uterus, the sloughing off between the two of them. The progesterone also promotes changes in your cervical mucus, whether it wants to be thicker to block bacteria and sperm from getting through, or thinning around the day closer to ovulation so that sperm can get through. The effects, I was going to say a placental progesterone. So if you if you are pregnant, the placenta in the baby will make its own progesterone around starting at month 3. It will inhibit your uterine motility so that your uterus doesn't contract. And I'm like, other things will make that go away around 9 months, but until then, progesterone makes it so your uterus is not contracting on that developing fetus, and it helps prepare your breasts for lactation. So kind of get your breasts active. The female sexual response, some of this similar to males, initiated by touch, any type of psychological stimuli, your clitoris, the vaginal mucosa, and the breasts all will engorge with blood. Your vestibular glands, again, in the vestibule area, the entrance area, they will all start to create secretions to help lubricate the vestibule and neutralize any acidic urine that might be there, similar to the bulbourethral gland or the Cowper's gland. An orgasm is accompanied by muscle tension, increase in pulse rate, increase in blood pressure, and the contraction of your uterus. Again, the uterus will contract and will do a reverse peristaltic contraction to try to get sperm closer to the top of the uterus. However, even though, yes, it helps contract the uterus to go reverse and up, it doesn't mean an orgasm is necessary for conception. The sperm can still swim all on their own. Now, developing, and I'm like, what's actually going to make you hit puberty for a female? A lot of it's your follicle-stimulating hormone and luteinizing. They're elevated at birth, kind of like high levels of testosterone at birth, and then it goes back down. It's that follicle-stimulated luteinizing stays low until you get to during your pre-pubertal years before puberty. However, as you are growing, your organs, your reproductive organs are still going to grow, and they start to become functional at puberty. When you can actually, I was going to say, maintain pregnancy, get pregnant, maintain pregnancy, you are considered you've now hit puberty. It means now you're releasing those you're releasing those eggs, you're ovulating. That's all in response to your gonadal hormones, the follicle-stimulated luteinizing affecting your ovaries. Your secondary sex characteristics are all going to appear around puberty thanks to your estrogen and progesterone. Otherwise, before puberty, reproduction is not possible. You need the rising levels of all of your hormones to get your ovarian cycle going correctly and your uterine cycle working correctly, because you need both to happen for pregnancy to occur. Menopause, everything goes away. The word itself means the stopping of menstruation. Now, we consider someone in menopause if they have not had they have not menstruated for a full year. There is no equivalent to menopause in males. Males will continue to make, they'll continue to make testosterone, continue to make sperm throughout their entire life. The levels may go off, but it doesn't stop. So they can do it, for their entire life. However, because of menopause, we're not having those increases of estrogen anymore. I'm like, again, we need rising levels of estrogen to create, to develop those eggs. And I'm like, to have those eggs be released. Well, if we're not releasing any eggs anymore, we don't need the estrogen. And all of a sudden, you're going to have a decrease in estrogen after menopause. Now, this decrease of estrogen is going to cause an atrophy of your reproductive organs and breast tissue. And so we don't need the uterus. The uterus is normally the size of a pear. And I'm like, it looks like an upside down pear. After menopause, it will shrink down to about the size of a walnut. And I'm like, don't need the uterus anymore, so I don't need to maintain something as large as a pear. And I'm like, so your reproductive organs will go away. that breast tissue will atrophy, and I'm like, and the muscles supporting ligaments underneath will atrophy, meaning they will start to sag. You may have some irritability and depression. Again, it's the hormonal levels. It's like reverse puberty going through menopause. All of a sudden, puberty, your hormone levels are still off a little bit till they get regular. It's kind of like the reverse. Instead of all these levels are increasing, now they're all decreasing, and you can get hormonal. You may have hot flashes, because all of a sudden you may have like bursts of estrogen, because it's like, oh, everything's going away. But all of a sudden, oh, just kidding, we've got a little estrogen. This estrogen will actually cause dilation of your blood vessels, especially in your skin. If all of a sudden you have a lot of blood rushing to your skin, you feel warm, hot flashes. Your skin will start to get thinner. You will have bone loss because estrogen facilitates calcium uptake. And you're going to have increased blood cholesterol levels because estrogen also helps keep those levels low. Never anything good. And so you're like, well, if you have declining estrogen levels that cause all of these bad things, why don't we just give you estrogen? And they did that for a really long time. They did it just, estrogen or hormonal replacement therapy. And so they gave people estrogen and progesterone. However, they followed those females later on in life, and they looked, and people that were given estrogen to replace the lost estrogen they weren't making, had a 51% increase of heart disease, 24% increase of breast cancer, 31% increase of stroke, and the risk doubled for dementia. So they're like, well, let's not do that anymore. And so they generally don't give you estrogen replacement anymore. They may give you, and I'm like, small doses of estrogen to reduce some of the symptoms if you've got really bad irritability, really bad hot flashes, other symptoms like massive bone loss. But they're generally not going to do that. They want to look to see if there's breast cancer in your family. Do you have the genes that may increase your chance for breast cancer? Because they know, breast cancer will increase if they give you estrogen. And so if you already have predisposed conditions, they won't do it. They're pretty much, okay, good luck. You're on your way. And finally, my last of the review questions. So find your colored note cards. And the question, ovulated oocytes enter the uterine tubes, fallopian tubes, whatever you want to call them, blank. There you go. Via undulations of the fimbriae that draw in that egg cell. Again, they're going to try to create that current since they're not attached to hopefully catch the egg. The what of the uterus receives the embryo and provides nourishment until the placenta is formed. Pink, orange, yellow, or green? Which one receives the embryo? It is the pink, the endometrial lining. It will nourish that fertilized egg until the placenta can start doing that. Which of the following are risk factors for the development of breast cancer? It's all of them. But again, doesn't mean you're going to get it. A woman who wants to ensure conception might buy an ovulation predictor kit from the dollar store. Which of the following hormones, when detected by the kit, would be the best indicator of imminent ovulation? It is the luteinizing hormone. It's that huge spike in luteinizing hormone that causes ovulation to occur. What part of the sexual response do females never experience that males do? Oh, I didn't talk about this. It's not pink. it is the yellow. A female does not undergo a refractory period, meaning they can have multiple orgasms. Males have to wait a while. Females, when you're like, whatever, females don't get erections. There is the same tissue in the clitoris that there is in the male penis that causes an erection. So the clitoris still fills with blood and is considered erect when it fills with blood. This is the stage of life in females when reproductive hormones decline and menstrual cycles become erratic. It's the end, menopause. Around the age of 50-ish, give or take.